Hi everyone, welcome back. My name is Hina Mazarudin and I am your Vice President for PAs in Virtual Medicine and Telemedicine. Today I'd like to continue a series of where we highlight some of our amazing PA members and how they work in their respective fields and utilize telemedicine. My intention is that this serve as an opportunity for us to connect and network together and also to highlight our amazing members. You know I believe that we are stronger together. So without further ado, let's get started. Hi everyone, welcome back. Thanks so much for joining us. Today I have another amazing PA who works in a very unique specialty joining us and utilizes telemedicine. Let me introduce you to Ed. Ed, how are you doing today?
Great, thank you. It's nice to be here. Thank you for having me.
Thank you so much for joining us. Can you start by sharing your name, how long you've been a PA for, and tell us a little bit more about interventional radiology, especially as a PA, please?
Great. Ed Mathis. I've been a PA probably longer than most of you have been born, 40 years this year. I graduated from what was Hahnemann Medical College, now Drexel University in 1981. So it's been a very varied career, 15 years in surgery, all phases of surgery except orthopedics, 10 years in internal medicine. And that 25 years of experience prepared me for the position that I've been in for the last 15 years, interventional radiology. I've had an interest in radiology since the beginning. I saw one of the very, believe it or not, one of the very first CAT scans ever done. It was a brain CT done on a one slice machine that took, I think, 3.5 hours to complete.
Oh my.
I was hooked by that technology, and look how far we've come. So 15 years in IR. I was the radiology review editor also for the JAPA, late 80s into the early 90s. There weren't a whole lot of PAs working in radiology at the time, and we were trying to drum that up. And it really didn't open up until we saw the big surge in about the late 90s when they changed some of the residency requirements, which is what bumped up the positions available for PAs.
That's amazing. Thank you. Can you tell us a little bit more about your experience with telemedicine, especially in the field of IR?
Well, IR, everybody looks at IR as a procedure-oriented uh, specialty, and it is. We use little tiny needles, little tiny wires to do things that they used to do in the operating room. Some still do in the operating room. A good example would be vascular surgery. Nothing is open anymore. It's all endovascular. It's radial or femoral artery access, put in a needle, put in a wire, a sheath, and have at it, balloon, stent, do everything. That was invented by interventional radiology. The first coronary artery angiogram was done by an interventional radiologist. So we've been at the forefront of advances in technology, and this is minimally invasive surgery. My very first case on my very first day in interventional radiology, I got dragged into a room at the end of the day for an upper GI bleed. Emergency TIPS procedure, for those of you who work in surgery, would know what a portocable shunt is. Now, when I worked in surgery, we did a portocable shunt. We would bypass the portal vein to the vena cava in a 12 to 14 hour surgery using a graft. This procedure took 45 minutes through an internal jugular vein approach into the hepatic vein, finding the portal vein, putting a stent in, and we were done. And I was hooked then. So a lot of what we do is procedure oriented: tunnel central lines, paracentesis, thoracentesis. I do a lot of very complicated CT guided biopsies in areas that other folks can't get into. I've done several thousand lung biopsies. I'm kind of the go-to person in upstate New York if you've got a difficult lesion or if they really need a tissue sample. Telemedicine has always been part of, even before it was the thing. It's been a part of what we do. I have a half a clinic day. It's not enough time to see clinic patients. I don't really need to see a patient in person. This works. I'm looking at imaging. I'm talking. I'm getting a history. I'm explaining the procedures to them, risks, benefits, indications, the post-op course. and getting them ready for the procedure. It's a lot easier using video conferencing. Most of ours is video conferencing. I do have some slides that I do share over that video with folks when I'm going over their procedure. So that's the pre-work, and then we meet. We meet in the prep area prior to the procedure, but they've already met me online. I'm not some bozo walking into a room saying, "Hi, I'm going to stick the biggest needle in the world into a place in your body it was never meant to go." They already know what the procedure is about and they're prepped for it.
Absolutely. So it sounds like it's been a great way for you to connect with the patients, to explain the procedure, make sure that everybody is comfortable. And then when you meet them, it's a familiar face instead of it being so, kind of a foreign thing. Like you said, walking in saying, "This is the biggest needle that we're going to put inside of you."
That's how I describe my specialty. Post-procedure, it's easier to follow up patients post-procedure. It used to be a phone call and I'll see you in clinic in 2 weeks. Now I do it video. Most of the only time they have to come in is if I've placed a drain and I need to pull the drain out, or if they have a peg tube, a feeding tube in place, and they're having some issues with it. Most of the time they'll show their camera down to the wound site. We'll take a look and say, "Great, it looks good, keep going." So we only bring them in now to the clinic. It saves them time, it saves us time, it's a lot quicker.
Sounds like it's definitely efficient for both our patients and our providers.
Absolutely.
Wonderful. Could you tell me a little bit about what you like about telemedicine and what you find to be a challenge, please?
I can see more patients with telemedicine. At the beginning, it's cumbersome, of course, because you're both trying to get used to the technology. But a year in now, I think most everybody's familiar with Zoom. Again, I like it. I can get to know the patient. We can talk like this instead of being very formal in an atmosphere in a sterile room with lots of stuff laying around, and my face is buried in a computer. Now I can bury in the computer and type while I'm talking to them. I'll have another window open on another screen with the electronic medical record. And I think it's better for the patient, it's better for us. Disadvantages, hands-on. Sometimes you need to touch the patient. You need to be able to do that. And my fear is the physical exam, the art of the physical exam is going to be lost. Although all you young guys are and women are making inroads into using other skill sets to assess the patient physically. So all this online monitoring and home monitoring stuff, equipment that you can get now is really, I think, revolutionizing how you practice medicine.
Wonderful. If you could share with us a message or a pearl or some kind of, tip or bonus point for our PAs and our PA students, what would that be, please?
Treat everybody the same. There's a human being on the other side of that needle, and they're scared. And you have to recognize that. I talk a lot, and I find that distracts the patient while I'm doing procedure. So anything you can do to make the patient comfortable is good. On the procedural side, my big thing is trying to make it as pain-free as possible. Not everybody does that. Use local anesthetic, give it time to work. It needs a minute or two to reach full effect. I've gotten in the habit of giving local anesthetic and then setting up my table for the procedure while I'm waiting for it. It forces me to slow down. Be attentive, listen to what the patient has to say. Nobody wants to hear what you have to say until you tell them you're going to stick a big needle in them somewhere. But sit and listen to what they have to say, and really listen, and get your face off the computer screen if you can, your nose out of the computer screen. Those are my pearls.
Thank you so much, Ed. And thanks everyone for watching. And we look forward to seeing you back for our next episode. Thanks so much, everyone. Take care. Bye.